Welcome back, and thank you for staying with KTN Prime. Now let's begin our conversation on Social Health Authority and the implementation of it. As you're aware, the Rural and Urban Private Hospitals Association, together with the Kenya Association of Private Hospitals, they did suspend SHA services for now. But what exactly is happening? Is SHA really working? Well, that's what we want to talk about with my guests next to me, Reverend Joseph Kariuki, who's the Deputy Chairman of the Rural and Urban Private Hospitals Association, and next to him, Dr. Eric Musau, the Chairman at the Kenya Association of Private Hospitals. Thank you, gentlemen, for making time, and good evening.
Thank you. Good evening to you.
All right, let's start with the big key tonight, because we had a story on SHA and the issues that you're facing in private hospitals. And we asked our viewers if private hospitals, the question was, should the government reinstate the old NHIF system? And majority of them did agree that maybe it's time to revert back to NHIF. But is it the smartest move? Maybe I'll start with you, Dr. Ari.
Well, thank you for hosting us today.
Karibu.
And one of the things, just looking at your question, should we revert back to NHIF? My answer is a firm no. And the reason is NHIF had its fundamental failures.
Okay.
In that it was largely focused on the treatment side of things, what we call curative services. And there was very little focus on preventive, promotive services. And history and research shows us that it's cheaper and more cost-effective to focus on preventive services rather than curative services. And then secondly, NHIF was a members club. It was a private members club. So essentially what this means is that you had to pay for you to be a member. Okay. And to enjoy the benefits that come in. So essentially this was private money to take care of the Kenyan citizens. So the ideology behind SHA was really great because it had to sit down and look at the financial sustainability of the social health, of the National Hospital Insurance Fund, then remodel it in such a way that it is going to be sustainable. So one of it was establishment of the Primary Healthcare Fund, and this was to provide a basic level package to any Kenyan, whether you can afford, whether you can't afford it, so that at least that avails what you may call the promotive, the preventive service, occur at that level. Then there are some services that initially were not funded under SHA, under NHIF, that now had to be included, like emergency and critical care. And because the burden is quite high financially, it was an imperative for the government to establish a fund that would be directly financed by the exchequer. Yeah. So the failures in SHA have largely not been from an ideology perspective, but from an implementation perspective. Okay. So it would be unfair to criticize the ideology without looking at where we went wrong.
Okay.
Yeah.
All right, picking up from where he left off, Reverend, if the problem is not the ideology behind it, it's the implementation, where are we getting it wrong?
At the same spot, actually, at the place of implementation.
Okay.
And I guess, like Dr. has put it right well, the formation of NHIF needed to be worked on. Remember, NHIF was formed and fashioned specifically for salaried staff, and initially it was government staff. And it is the process of reforms that have come along the way that was shifting it towards taking care of other people, including the self-employed. And so once those reforms maybe became so many, and it got to a time where the government said, now we need to relook at the healthcare system in totality, probably after 60 years of existence.
Yeah.
So all these things, the reforms that were suggested, they were proposed because we needed to relook afresh at the way we provide our care as a country. And I also support Dr. that going back to NHIF is not the solution. The solution is just doing the right thing in the place of implementation of what we already have right now.
All right. So let's now talk about the issues that private hospitals are facing that led to the suspension of SHA services. I mean, what exactly is the extent of the suspension? How many facilities are affected? And what happens to patients who are seeking medical services from these facilities, Dr.
So just to clarify, we are not turning away patients.
Okay.
Basically, what we have done is suspension of credit arrangements between providers and the insurance, because we work on a credit system. We provide services, and then we are reimbursed contractually within 90 days. But the reason why we suspended credit arrangements is because there are outstanding debts that have not yet been cleared. And what this does is it becomes difficult for facilities to continue operating because they are cash strapped. We require money to buy supplies. We require money to pay salaries. We need money to buy drugs. We need money for operations.
How much is owed to you?
Cumulatively, both public, private, and faith-based facilities are owed approximately 30 billion by the National Hospital Insurance Fund.
Coming to you, because that figure seems to be changing. We've had 30, we've had 20 billion. Just today, Robert Ingasira, who's the acting CEO of SHA, claims that initially they owed health providers 19 billion. 9 billion was paid between October and November. I believe there's a press statement that was equally released that they're saying they've released around 5 billion. Where are we? What exactly are the figures?
All right. Let's start with the 5 billion that was released a day ago. That is SHA money. And that is not where we are. That's not what we are discussing. What we are discussing and talking about is the NHIF old debts. We call them legacy debts. And that one accrues all the way from 2017. And the figures keep on changing because at some point they had started reducing the figures.
Yeah.
But what Dr. Ari said is the true position, that what it is owed is 30 billion across the sector.
Was there initially an agreement on how they're going to pay it, even as we started the transition to SHA?
There was no tangible, there was nothing written, there was nothing agreed on during the transition. The word was, when SHA comes in, it will take over the assets and the liabilities of NHIF. And so it was like a continuation. But because they expected a little more money collected from the citizens for financing SHA, then there will be something to be paying back what was owed by NHIF.
So then where does that leave you, Dr. Ari? Because SHA claims they do not have contracts with associations.
So, yeah, it's true. SHA does not have a contract with associations, but we represent members' welfare. And all providers, whether public, faith-based facilities, need to ensure that they have what I may call a sustainable working environment, because this is not just a private sector problem. It's also a public sector problem. The same debts we're talking about, 30 billion, are also inclusive of public sector debt. And I'm sure very soon you will hear conversations around the public sector debt from the Council of Governors, because they are also facing the same crisis. I think just the other day we saw the chairman of the KEMSA board stating that they are owed a substantial amount of money by counties. And these monies are actually, if you work it backwards, they will just be traced back to unpaid NHIF claims. So the failure to settle these debts has far-reaching consequences beyond providers, including suppliers. And as the Reverend has mentioned, that when it comes to SHA and NHIF legacy debts, remember at the end of the day, it's the same patient. We have the same suppliers. Our suppliers don't recognize that this is a SHA account that we are operating with a provider, and this is an NHIF account. It recognizes a singular account. So if providers are owed money and NHIF, and we need to keep providing services under the Social Health Authority, then it becomes difficult because you'll need supplies from the same suppliers that you owe money.
How far do the pending bills go back?
From pending bills in terms of
what is owed,
so
NHIF areas, that is.
Yeah, as Reverend said, all the way back to 2017.
But someone might argue,
Yeah.
2017, we are in 2025.
Yeah.
Why did we let it prolong?
Yeah, that's a good question, and I wish the CEO SHA was here to also answer that, because one, we used to operate an old e-claim system that was completely locked, and providers have no access to that system for reconciliation. And providers have been very patient, because the conversation around it has always been, we are working on it, we'll reopen it, we'll be able to continue paying you. And it's getting to a point whereby reconciliation process is not yet complete. There is no full acknowledgement of the exact amount that providers are owed. And as we are continuing, even with the SHA claims, on average, most providers will tell you that only 50% of the debt has been settled. So you still have a bit of SHA debt that is accumulating. You have a legacy debt before. And even more important is the sustainability of SHA moving forward. Because just the other week you heard in Parliament that out of the 18 million registered members, only 4 million are contributing.
Yeah.
And that works out to around 20% active contributors.
Only those salaried, actually.
Yes, only the salaried
Yeah.
ones. Given that 85% of our economy is, or rather employment status in Kenya is from the informal sector. So this raises a lot of sustainability questions, and providers are wondering, even if SHA was to settle the debts today, will it be the scenario 6, 7, 8 months to come? Will Kenyans continue contributing as they're supposed to contribute, or what will happen? So that has been our main concern.
Okay.
So unless these fundamental issues are addressed, SHA might end up being a hard sell for Kenyans.
Which at the end of the day, Kenyans are the ones that are suffering.
Yeah.
But yesterday you had a meeting. What came out of that meeting? And who was involved in that meeting?
Okay. Maybe I add something from
Sure.
what he said. You asked a good question about why we have been quiet since 2017 to date. I would like to put it clear that between 2017 and 2023, when NHIF folded, NHIF had different systems across. They had changed their systems almost 4 or 5 times. Remember, initially in 2016, 2017, we used to take our physical claims, paper claims, and we will drop them in a box somewhere for them to process. Now, when they brought the first e-claim system, all the claims that were physical claims, they were actually archives. They were put in an archive somewhere. We took off with the e-claim, and we moved on with it. At some point, they said it had a lot of loopholes, and they wanted to bring in a new system. All the claims under that e-claim were archives. We moved to another claim until the recent one, which is the hike system, which also they also closed the other day when SHA was coming in, and it also had some money in it. So many claims. So when you ask why from 2017, that will be a better explanation for you. So we are talking about money that has been archived, yet it was spent at the hospital level, but not paid at NHIF level.
Yeah.
On your question about yesterday's meeting, the RUFA leadership was meeting with the PS, Medical Services, Mr. Kimtai. We had a 3-hour closed-door meeting, but we didn't come out with tangible things that we can say we agreed on. And we had to stop at some point and agree to continue with the discussions later in the week, probably on Thursday.
You know, our viewers are curious, when you say you didn't come up with tangible things, what exactly was discussed?
Tangible, because the things that made us stop or suspend service were not addressed. We presented our case earlier, and we expected that by the time we were meeting, they would have looked at it and at least come up with some solutions to some of those things. And some of those things, you know, our issues were just 2 issues. The first issues was that legacy debts of NHIF. And the second one was the outpatient capitation model that they brought in with SHA. For us, we looked at it and we said it is not workable.
Yeah.
So those 2 issues are the ones that made us suspend the service, and they were not addressed at that meeting.
How exactly is the outpatient model unrealistic?
When you look at it, you realize that it allocates 900 shillings per member per year. And if you divide that 900 by 12 months of the year, you come to something under 75 shillings a month. And looking at it again, there is other aspects that they brought with it, saying that they will be reimbursing according to the disease burden. That means septicemia will have some weight, flu will have some weight, pneumonia some weight. And so looking at it, it was a lot of calculations, which we also challenged them and told them, even them, when they want to do a reconciliation, it will be very difficult for them. Okay. We needed something that was straightforward. Okay.
Dr. do you think there is enough goodwill to ensure that this situation is actually solved?
Well, I think this being the second day since the suspension notice was issued, we are waiting for invitations, especially from Kenya Association of Private Hospitals, from the relevant stakeholders. So we are talking about NHIF, SHA, also the PS and the CS Health, so that we can be able to sit down and discuss and see how do we address this impasse. Because at least one of our expectations, I'm just shy of calling it an irreducible minimum, is a bit of a disbursement of funds to settle at least a significant percentage of what is already at the EFT stage as far as the NHIF legacy debt is concerned. There are claims that are already at the EFT stage. We are working with approximately around 10 to 12 billion. These monies were already vetted, verified, and acknowledged as clean payable claims. They are just waiting availability of funds and then paid off. So we are expecting at least a conversation around the disbursement of those figures. As well, when it comes to the Social Health Authority, we also want to get a bit of clarity on, when will this system be actually complete? Because it's still being developed as we talk. Not all modules are fully operational. Okay. Number two, we also need clarity on the reimbursement model for outpatient. I have just seen on the notice that the CEO shared was that the training will start on Thursday. Yeah. So there's still a lot of fundamental question with this reimbursement model. It is poorly understood by even the staff themselves in SHA. It's a very complex academic payment model. It has never been tried before, so we just don't know how it's going to work out.
So we are testing as we go?
We will test as we go.
Okay.
Yeah.
Let me just go back to that particular statement that was released by the Social Health Authority. It says that RUFA facilities have been trained on accessing claims through an online dashboard and enabling them to track their payments efficiently. When you said that the previous systems that became archives, for lack of a better term, were you able to track your payment?
Those systems are already closed.
No, before.
Yes.
Okay.
Before, they were very transparent. We were able to see the patient right from the entry at the point of care in the hospital. We were able to see how our claim is progressing. Stages of internal audit, stages of accounting, up to the very end at the EFT level, where they call the bank files. And from where I sit in my facility, I can comfortably be waiting. When they release funds, I know so much is expected to come to me.
How often did they release those funds?
When all things were working well, they were even doing twice in a month, which was a bit comfortable for us.
Okay.
Yes.
You want to add on to something?
Yes. I think just to give credit where it's due, the old NHIF claims management module was probably the best claims management system, much better than what is available in the private sector to date. Because you could be able to track your claims, you could be able to know what stage your claims are in, and you could also be able to do a reconciliation on the same, and the figures were almost always tallying.
Okay.
So this particular system that we are using, as I said, it's being developed on the go. So we are getting, the developers are getting live feedback. A lot is not operational. Even has been mentioned there on how to access those claims. It is not yet fully loaded. Not yet, that are recorded on the system that haven't reflected to providers' bank accounts. So there are a lot of inconsistencies that are yet to be addressed.
Okay.
Yeah.
When you talk about payments, they claim that there were payments that were released in October. Did you get any?
Which claims, SHA or NHIF?
Well, this is coming, NHIF claims actually.
Yes.
As of October 4th, 10 billion out of 19 billion in undisputed NHIF claims has been released and been paid. Did you get that?
Yeah, so the last disbursement was 31st of October, if I recall, and that was to settle the old NHIF debt. But remember, this debt had been accumulated for quite some time, with the last set of claims being raised on 30th of September, just a day before launching of the Social Health Authority. Yeah. So one of the most important things as far as that disbursement is concerned is that since then, providers have not received a single coin. And now we are moving to the 5th month without settling of any amount of the legacy debt. Okay. So the general assumption in SHA is that just because the SHA claims are being paid, providers should be content with the fact that there is money flowing, but they should wait as SHA finishes working on the reconciliation and then subsequent payments. So we don't have clear timelines as to when and how these payments will be done. Okay. Yeah.
One more question on that. So when they release these funds, does it get to all facilities, or do some get and others don't?
So previously, before we had all these cash flow issues with NHIF, yes, all providers would get as long as your claims were at the EFT stage, which is something you could see. And you even had a rough idea how much you're expecting as payments. Okay. With when the liquidity problem started, now the disbursement criteria changed. So monies were allocated a bit differently. So there was a bit of priority that was accorded to providers who are in the dialysis space because of just the sensitivity of the services they provide, oncology. Sometimes Linda Mama claims could be forgotten. In some cases, the disbursements came with some instructions where a certain percentage would go to public facilities, another percentage to faith-based facilities. So there was a whole criteria that was being used, and most often than not, some providers were often left out without getting paid. And even those who were getting paid were receiving a very small percentage of their total outstanding debts. Okay. You would find that SHA owes you around 1 million shillings and you get paid 30,000 or 50,000, for example. Okay. Yeah, so it's almost inconsequential.
Oh. Well, okay, Reverend, coming to you. I mean, as we wait for this particular issue to be solved, how do we ensure that Kenyans get uninterrupted health services?
It's difficult because that service comes with money, but we have given some, suggestions to SHA and the ministry on how we can get back to the services. And one of the easy things that we asked them to do is that, yes, they paid the 9 billion in October. That's part of the legacy debts, but there is that 10 billion still owing. And we told them, since that 10 billion is on the stage of account payable and EFT, which means so that if they do that tomorrow, I'm sure services will resume as soon as possible.
I want us to take a short break, but when we come back, I'm curious to know, is there a clause that bars facilities from withholding services? We'll be talking about that shortly. But first, let's take that break.